All right, everyone, I'm going to ask you to take your seats. We're going to go ahead and get started with our next session. So please go ahead and take your seats. This is going to be Beyond the Muscle, Navigating Sleep and Pulmonary Challenges in Myotonic Dystrophy with Megan M. Lowery. So without further ado, here is Megan.
Good morning or almost afternoon, everybody. So my name is Megan Lowery. I'm a pulmonary critical care and sleep physician here at UF, and thank you so much for having me. So we got to wake everybody up a little bit this morning so we can talk a little bit about the challenges of sleep and respiratory muscles in myotonic dystrophy. So there's a lot to cover. I could talk about this all day. So we're going to hit on some of the heavy hitting topics and some things that aren't often discussed. So we hopefully will have some time for questions at the end. Okay, so let's start off with sleep and all the things that can affect it. And this isn't just unique to myotonic dystrophy. This is something very common in the general public, but excessive daytime sleepiness as well as fatigue. And we're going to talk about how we start to differentiate between those things. REM sleep behavior disorder, which is a narcolepsy-like disorder that we see in type 1 myotonic dystrophy that we're still doing research on, that we still need more information on. Circadian rhythm disorders, so people who tend to wake up really early, those early morning birds, and people tend to go to bed very late, are night owls. And then sleep-related movement disorders, things like restless leg syndrome, kicking your legs at night, having nocturnal leg cramps, all things that can really disrupt your sleep and make it difficult to feel rested the next day. And then something you've probably already heard about, sleep-disordered breathing. And this is where we lump in sleep apnea, and I'll then transition into some of the respiratory issues with myotonic dystrophy. So when we talk about some of the respiratory issues with myotonic dystrophy, it's really an overlap with sleep. So the same things that affect our respiratory muscles and that ability to take a deep breath in also can affect the muscles in the mouth that can lead to airway closing at night and sleep apnea. Those things in combination can sometimes lead to the inability to take a big enough breath when we're sleeping. And we can see things like hypercarbia or that high carbon dioxide at night. And that can have some symptoms the next morning when we wake up. We can have some difficulty clearing our airway, coughing enough to get the mucus out. And that puts us at risk for some infections. And the big complication with respiratory involvement is respiratory failure. And my job as a pulmonologist, as much as I'm able to, is to try and prevent us from getting to the point where this becomes an emergency and we end up in the hospital. So a lot of the respiratory things we talk about are preventative. So let's talk about how these interplay. When we're talking about muscle weakness and sleep disorders, we see an overlap with movement at night. So people might kick their legs or feel this urge to move at night. And when we talk about sleep disorders, I typically refer that to people who are excessively sleepy or have an internal clock that's just a bit off of the social norm. But there's definitely an overlap between the respiratory function, sleep, and muscle weakness. And when these interplay, we tend to have a lot of symptoms or things with sleep disordered breathing or generalized fatigue can be the complaint. So fatigue, how do we define that? Well, the truth is, in the English language, we do not really know how to separate fatigue from sleepiness. In the medical community, or not just DM, but in general, we try and associate what we call objective excessive daytime sleepiness and hypersomnia by giving a score to how easily you fall asleep sitting here in this lecture, driving in traffic, at the traffic light, in those meetings, in college classes. And that helps us try and put a number on how sleepy you are, but the reality is it's much more difficult than that. And so when we look at fatigue, there's probably a number of people out there who just feel like they can't get enough oomph and energy during the day. I, for one, have felt that. I've had those days where Netflix and chill seems like the best option. But when that becomes every day, that's where the fatigue comes into play. And this is very prevalent in both type 1 and type 2 myotonic dystrophy. So, how many people suffer from fatigue? In type 1, over 90% of patients in questionnaires report feeling fatigued. And this actually increased with the number of CTG repeats. So there is a genetic component to how this is translated from the lab to your DNA and what we found and how that comes into clinic. When you tell your doctor or your clinician, I just feel fatigued, I feel tired. Now, one of the interesting things that we found is that how does this impact your everyday life? And so while fatigue was more commonly presented in patients as they age, the fatigue impact score was more commonly associated with younger age. So younger people felt the fatigue more than older people. And maybe that's because if anyone's like me, as you get older, you slow down a little bit and don't feel the need to do as many things as when you're younger. But maybe that's not all there is to it. In type 2 myotonic dystrophy, something very similar happens where, again, 89% are having this fatigue. And yet, how do we differentiate to how that makes you feel during the day? Now, one of the things with type 2 is that men and women were a bit different. So while women with type 2 felt maybe less fatigue than men, it impacted their day-to-day life more. So there are some sex-related differences in how we are perceiving or how that's playing a role in our day-to-day life. So how do we work up fatigue? So we look for sleep disorders. We look for other labs. We make sure that the kidney and the liver are healthy. We make sure that the thyroid is not causing an issue. And very commonly, vitamin D and vitamin B12, because those also all can contribute to this. But also having lung involvement, having heart involvement, and some of the medications, beta blockers, metoprolol, carvedilol, very common medications we use when the heart is affected, can also cause fatigue. So it's very hard to pinpoint this, but it's important that we look at this the best that we can when you're coming into clinic and letting your clinicians know so we can try and whittle away at the things that we are able to control. And when we look for excessive daytime sleepiness, so these are the people who come into clinic and I'm running late and I open the door and that head pops up because I know they fell asleep waiting for me because I'm always behind, and that's okay. But there are some things that we can potentially do about this. We know that excessive daytime sleepiness is a bit more prevalent in type 1 than type 2, though overall our studies, we have more of it in type 1. So potentially we're just missing a whole cohort of people that could be affected with type 2. Now, important things that we do in my office is we look for sleep disordered breathing and we look for that high carbon dioxide that could be playing a role. There are a lot of neurotransmitters that go into the wakefulness cycle, and I wish we had a really great grasp on this, but the reality is that we've done the best that we can, and this is still evolving and developing. And one of the things that we know is that potentially some of the genetic mutations in myotonic dystrophy are disrupting this pathway somewhere along the line. And I hope that one day we'll have more research to better target these pathways. So when we look at excessive daytime sleepiness, it comes in just under the fatigue. And when we look at groups with type 1, we're looking at over 87% of people in questionnaires have excessive sleepiness during the day. And this is actually less in the younger age group, goes up as we get older. But when you look at the impact factor, again, younger people feel this impacts their day negatively more than those who are older. When we looked at type 2 myotonic dystrophy, a little less sleepiness, but still the overwhelming majority of 77% of people saying in their surveys, this is affecting me. And one of the things that we're here is that, again, similar to fatigue, women noted a higher impact factor. This negatively impacted their day more than men with type 2 who are also excessively sleepy. So let's talk about something that is not widely known. Let's talk about sleepiness in REM sleep. So REM is your rapid eye movement sleep. This is the sleep we tend to dream in. It is the sleep that it happens at the end of the night. If you wake up from a wild dream, you might be waking up out of REM. It is also an important sleep in muscular dystrophies because we're paralyzed in REM sleep, with the exception of our eyes and our breathing muscles. This is when we see the impact of respiratory muscle weakness the most. And we have now discovered that some of this excessive sleepiness that we're seeing in type 1 myotonic dystrophy actually could also be diagnosed if they came to my sleep clinic without that diagnosis of muscular dystrophy. They could potentially be diagnosed with narcolepsy. So we call this a narcolepsy phenotype, and it's seen in type 1 myotonic dystrophy. Up to 32% of patients, if we put them through sleep testing during the day, are not going to make it through 5 nap sessions by staying awake. They're going to fall asleep on average in less than 8 minutes. That's relatively quickly. So anyone who's asleep right now as I'm talking, come see me after. When we looked at the genetic testing, there are some people who actually carry the gene for narcolepsy. Now, this is not uncommon. It occurs naturally in about 30% of the population, and they don't necessarily feel sleepy with it. But the fact that we're having intrusion of our REM sleep during early phases of sleep, that is abnormal. That puts you more at danger for falling asleep during the day during unwanted time periods and having what we call pathologic sleepiness. So you're probably going to ask next, well, what about type 2? And the reality is we just have less research out there, but as you already know, our labs are working actively to address this further. But in type 2, while about 30% are still very sleepy, overall, they're not having this narcolepsy phenotype that we see in type 1 myotonic dystrophy. So what else can contribute to this sleepiness? So again, if you're one of those night owls and you came in here at 9 o'clock this morning thinking you were going to feel awake, you're probably a cup of coffee or tea drinks in for the day. And that's actually normal. And there's nothing wrong with being a night owl and wanting to stay up late and sleep in if that's your normal clock. But when you go to see your doctors in the middle of the day, you might report excessive sleepiness. And so this is something to relay to your providers. If this is affecting your ability to get to work on time or go to classes, there are things that we can do to shift your sleep and make it a bit easier for you to wake up in the morning. And then other things to ask about are what other sleep disorders could be contributing to this sleepiness. So when we look at excessive daytime sleepiness, I'm sure you've all heard of stimulants, very common ones being Ritalin and Adderall. We only have one study in type 1 myotonic dystrophy looking at Ritalin, and I can tell you that this is about 1/3 of the dose I typically give my narcoleptics. So I am not surprised that this didn't have a clinical impact on sleepiness in patients with type 1 myotonic dystrophy who were feeling super sleepy during the day. Now, what we did find is that another medication called modafinil or Provigil, which is a wake-promoting agent. Both of these are medications that are highly watched by the government. I have to sign in many times to prescribe these. It's all monitored by Big Brother because they all have a potential addiction potential. But when we use it for the right reasons, they can be very helpful. And in patients with type 1 myotonic dystrophy, again, our literature, our research is relatively small cohorts, but they had a significant decrease in the amount of sleepiness that they were having. And so this is a medication that can potentially be very helpful for people who feel excessively sleepy. Now, both stimulants and modafinil can have side effects that we have to monitor carefully. The big ones being headaches, insomnia if we take it too late in the day, loss of appetite, which is very important because we have to monitor the weight. And anyone who has a neuromuscular dystrophy, while we don't want people gaining a lot of weight loss can be an indication we might not be eating as much. And are we not eating because we're having trouble swallowing or because we're too short of breath to swallow? But if it's the medication, then that's something that we can work through. Now, the other issues with these medications is they can make the heart race. And so they have to be used with caution and monitoring in anyone who has a heart arrhythmia or indications for heart failure, as it can counteract some of the medications given by the cardiologists. So let's switch gears away from sleepiness to some other things that might not be too well known. So there are sleep movement disorders, one of which is restless legs. This is an irresistible urge to move your legs before you fall asleep. Gotta move, gotta wiggle, gotta jiggle, feel electric shocks. I feel uncomfortable. It feels like there are bugs in my bed and I cannot fall asleep. This is actually more common than we probably give it credit for. And then periodic limb movements. So this is more typically noticed by parents who watch their kids sleep because they're aware that the kids are kicking off covers, the kids are kicking in their sleep and moving around, and the kids don't necessarily know this. This can go into adults too. We just become less aware of it unless we have a sleep study showing it. So restless leg syndrome in type 2 myotonic dystrophy, this can affect up to 60% of patients. That's a lot. And it is very uncomfortable. It can make it hard to fall asleep. And this is something that in the general population might be there in about 10% of those with Northern European descent. But we really want to look for secondary causes because it can be very treatable. So things that very commonly cause this are iron deficiency. This is particularly important in young women who tend to have blood loss, and this can be fixed. And then we want to look for medications, Claritin, Allegra, Zyrtec. Those can all cause restless legs. Most antidepressants also can cause restless legs, and people might not put two and two together. Those aren't indications to stop the medications, but they are an indication to talk to your doctor to see what we can do about it. So our first line treatment, test for iron and look for things like sleep apnea that can be treated and fixed and help your restless legs. There are some other medications like gabapentin and Lyrica, which are first-line medications for treating restless legs. I don't get into the dopamine agonists, things like pramipexole and Requip very often because they tend to have an unwanted side effect of making the restless legs worse with time. Now, I have patients in my sleep clinic I have on opioid medications, things like oxycodone or Suboxone for severe refractory restless legs. These would have to be used in extreme caution and would not be recommended unless a lot of discussion, a lot of pre-planning and discussion of the risks, because those particular medications can cause respiratory depression and difficulty breathing, which may be more pronounced, obviously, in patients that have respiratory component of their muscular dystrophy. So what about the kicking at night? So periodic limb movements at night are normal. They can happen with sleep apnea. They may be nothing to worry about. They may not affect your sleep at all, but they could be an indication that you either might have restless legs, you might have sleep apnea, or that this alone could be affecting your sleep. And about 25% of patients, when used adult scoring, had a lot of periodic limb movements at night. And this is seen up to about 38% of children that had type 1. So moving away from the things that make us move at night, what about the things that make it hard to get out of bed in the morning? So our internal clock, those of you that suffered with me through this last cycle of changing the clocks a few weeks ago, if you're a night owl, you might have suffered a little bit more with that change, because when we move the sun, that really hurts us. And so this is very common in young people. It typically comes about in high school. Any parents out there have trouble getting their kids up for class in the morning? How many of you were late to that 7:30 or 8 a.m. college class because it felt better to sleep in rather than go? So this is not uncommon in the general population, but it's something that can be fixed with a sleep provider. So feel free to bring that up during your sessions. Now, the prevalence in particular with myotonic dystrophy, we don't know, but just knowing the amount of patients that I see in my sleep clinic, this is something always worth discussing. So we're going to change gears and look at the intersection of sleep and respiratory disorders. And the list could be even longer than this, but we're really going to focus on sleep apnea, obstructive and central, and then low oxygen and high carbon dioxide that happen at night comparatively to daytime values. So there is a big intersection for sleep disordered breathing, hypoventilation, and muscle weakness. As muscle weakness can progress, part of the affected muscles are our diaphragm. This is the big muscle in the chest that we use to help us breathe on a day-to-day basis. Now, you don't think about breathing too much during the day, but during sleep, every single person, no matter who they are, will take a shallower breath. And that can be more pronounced with neuromuscular disorders. And so it's something we have to be aware of, that there could be dysfunction at night. If we lose some muscle tone in our upper airway and our tongue and our mouth, which if anyone's seen a family member snore really loud after Thanksgiving dinner, those things can also contribute to sleep apnea, which is very common in the general population, but something we need to be more aware of in the myotonic dystrophy community. And then neuromuscular scoliosis. So the curvature of the spine and how that affects breathing can also be more pronounced at night. And these are things that can lead to additional sleep disorders or low oxygen and high carbon dioxide with sleep. There's also literature out there and things that we found that some of that relationship we have with our brain and how it responds to the low oxygen and high carbon dioxide may also be affected in myotonic dystrophies. So let's talk a little bit about sleep apnea. The prevalence might even be higher than what Dr. Subramoni mentioned in his earlier talk. So in DM1, it may be as high as 86% of patients, and in DM2 up to 58%, though my suspicion is that that is probably underestimated in DM2. We have obstruction, so airway closure, that can be part of that sleep apnea, or central sleep apnea, where the brain doesn't give us the signal to take a breath. Now, on sleep studies, I can tell you that it's very difficult to sometimes determine if an event is obstructive or central, because in neuromuscular weakness, sometimes that's hard to differentiate whether you're not breathing or whether we're just not seeing those respiratory muscles respond the way we want. So it's very important to be seen at a sleep center that knows how to look at these events in a sleep study. It is recommended that every pediatric patient with myotonic dystrophy at least once have a sleep study, and in adults who otherwise don't have other indications for CPAP or non-invasive ventilation, that they have a sleep study during adulthood. For me in my clinic, I prefer an in-lab sleep study. That gives me the most accurate information. It allows me to test carbon dioxide monitoring, but I order this very rarely in the type 2 and type 1 world, because I have other indications to help people breathe at night that I usually don't have to bring them into the sleep lab. So let's transition to the lung function because this overlap is really important. So we look as pulmonologists how big of a breath you breathe, how easy it is to breathe in and breathe out. That's all part of your respiratory function. And we recommend monitoring that at least every 6 months, sometimes sooner. Occasionally we'll do that a little bit later. But the guidelines really recommend that we're testing this very frequently so we can catch changes early. We also know that there can be changes that are just part of having a bad day or some other things that are going on that we might not see then with a follow-up visit. So when we look at sleep and lung function, one of the things we look at is your total lung capacity. So how much air you can take in and keep in. And what we found is that the lower your total lung capacity, the higher your sleepiness was on sleep testing and the higher risk you had of having sleep disordered breathing. And this just goes hand in hand with what we know that as muscle weakness can progress, we can see that translate into respiratory and sleep disorders. So what about that carbon dioxide? I test my oxygen at home and it looks good. So can my carbon dioxide still be high? And the answer to that is yes. We should be looking at different blood works, blood gases, regular lab work, something called bicarbonate, to help us get an idea if that carbon dioxide is high. And it's important because it can cause symptoms like headache, upset stomach, feeling confused, feeling tired and unrested. And it's an indication for us that we should be helping to facilitate breathing at night. So what do I do to help breathing at night? Well, I have one option, which is CPAP, or continuous positive airway pressure, that I use for patients that solely have sleep apnea. But as we start to have differences or more pronounced muscle weakness, I move to something called NIV, or non-invasive ventilation, which is a bit fancier than a CPAP. Those are things like bi-level positive airway pressure and can range up to even a home mechanical ventilator. And those are things to help support your breathing at night so that we rest the muscles so that during the day you can be more optimized to do the things that you want to do. And these are some of the different modes that I use, and there's a big long list. And I have kind of a checklist in my head when I'm going through who I'm going to order what or why I'm going to order something. But the reality is we don't get it right all the time. Sometimes we order a device that's not as helpful. Sometimes the settings on the device are not as helpful. So when you're struggling with this or you feel the device is not working for you, it's really important to talk with your providers because there's often a lot of things we can do with the machine to make it more comfortable. We recently had updated guidelines in the pulmonary sector in terms of how we look at patients and who would be a candidate for non-invasive. I will tell you that almost every patient I see in the adult clinic would potentially qualify for NIV. It is not common for me to see a patient who would maybe only be on CPAP. That is more typical of DM2, where I would not move to the non-invasive route. So when do I get a sleep study? Very rarely. When I have other indications for using non-invasive, I find that in the lab, people struggle to sleep. It doesn't give me the information I want, and it can be a super turnoff for using the device at night. And sometimes the benefit doesn't outweigh that negative aspect of coming into a sleep lab and being hooked up to everything. They're not the most comfortable things to go through. So what about if I feel short of breath during the day? What can I do for that? So this is something called sip and puff ventilation. It is actually connected to a ventilator, can be used during the day with a mouthpiece to allow people to breath stack. So So when you get short of breath, we inflate those lungs like a balloon so that your vocalization can be bigger, more clear. It's easier to talk louder and it's easier to eat. I have patients who use this intermittently when they're going out about on their day. They take it to their classes. It makes it easier when they're feeling that little bit of shortness of breath and gives the safety of knowing that there's help there if they need it. So they continue to be active in the community. That's very important. And the other reason that non-invasive is very important is that we know that patients who qualify, who get started at much earlier rather than later, end up having more preserved lung function. And there is a mortality benefit to being started earlier rather than being delayed. But it's not as easy as giving you a device and expecting you to use it every night. And these are the challenges that we go through in my pulmonary and my sleep clinic, because the devices are not perfect and we are not perfect. It takes trial and error to make all the settings. And if you've tried it and didn't like it and gave the machine back, you weren't the only one. If you can only tolerate it a few hours at night, you're not the only one. And if you think that this is unique to myotonic dystrophy, you can talk to hundreds of sleep apnea patients to why they have trouble with their devices at night. I wish they were more comfortable. I wish the masks weren't so stinky. I wish that they all stayed on and just weren't so much on the face. There's a lot of troubleshooting we can do in clinic. And so getting in with the right sleeper pulmonary provider that can make adjustments on your device so that it's comfortable for you, because this is a transaction. You give and I give. I make changes, I make recommendations, but you have to be okay with them. You're the one being asked to wear this. And so if it's not comfortable, talk to your doctor. They might not be aware of all the things they can change on the ventilators or the CPAP or the BiPAP to make it more amenable. And perfection, well, we're human. So we shouldn't strive for perfection. We're striving to make this a balance between what's helpful and what we can do feasibly at home. Some other things to talk to your providers about in terms of respiratory care is swallow function. And the reason swallowing is super important is because if we're swallowing things and it's not going down our food pipe, it's going down into our windpipe, and that can lead to infection. I said my number one thing is prevention. I hate it when I have to recommend a patient to go to the hospital. We want to keep people at home as best as we can, as long as it's safe. And part of that is addressing things like excessive salivation, too much spit in the mouth, waking up with drool on the pillow. There are medications and procedures that we can do to help with this. So bring it up to your provider if it's affecting your use of your NIV or if you feel like you're choking on your own saliva. We're going to talk a little bit here briefly about airway clearance. So another part of the respiratory status with myotonic dystrophies is being able to get the things in the lung out. That includes mucus, that includes things that get swallowed down in there. And there are many ways to do this. And I tell my patients, well, I want the best way. So I usually don't start with any of the things at the top of this list. Number one, I cannot do frog breathing. I unsuccessfully tried it many times at home. I think children are the only ones who can make these strange sounds that actually make this work. The things that I use are right in the middle there. So bag mouth ventilation and a cough assist. A cough assist is a device that pushes air in and sucks it out. It helps stimulate cough and it actually mobilizes secretions. That is a lot more effective than a vest. Vests shake up phlegm. They don't help you cough it out. So I am very strongly believe that my patients with neuromuscular disorders should be using a cough assist if they have difficulty coughing out phlegm rather than a vest. Manual maneuvers are not something I regularly recommend because a lot of patients have been on steroids. They have been having issues with pain, and those kinds of maneuvers can be really detrimental. We don't want to cause a rib fracture. We don't want to cause you pain just to get out things in the lung that we don't want being there. And the last part that I've been nagging a lot of my patients about, and I do nag, and I'm okay with being a nag, is how much muscle strength we can preserve. I wish I had great studies to say that doing things X amount of times a day with these, what we call inspiratory muscle trainers, would preserve a certain amount of lung function, but I just don't have it. But anecdotally, I can tell you with my patients, the people who are more active, the people who are challenging themselves with movement, do better overall and feel better overall. And these two devices up here are just two examples of what we call an inspiratory muscle trainer. This is not a plug for Amazon, but you can get them on there. What they do is they make it a little bit harder to breathe in and a little bit harder to breathe out. And what that does is it simulates weight training for your lung muscles. So the same way that some people right now are over in a talk about movement and exercise, I'm a huge proponent of that. But sometimes it's not feasible. Sometimes we can't get out, we can't go walking, it's not safe, we're at work, we're in classes. These are easy to whip out of your purse, take out of your bag, keep one in your desk. Do when you have time, do when you're watching TV, playing video games, reading a book. It's easy to have around the house. It gives you something to challenge your respiratory muscles. And it's something that I strongly believe in and hope that one day we maybe can have some guided programs to help with lung function. This has been a lot of information. I can tell you that I am very grateful to be here today, and I just want to open this up for any kind of burning questions you have, whether it be sleep or respiratory.
And once again, I'm going to be coming around with the microphone for you to say your question into for Dr. Lowery so we can all hear it.
Don't be shy.
Thank you.
For the cough assist machine, how does that work? And if I'm using it at home, what do I need to know?
Great question. So the cough assist machine is a machine that gives a pressurized air, puffing it in. If you've ever blown up tires in a car, it's a similar system. If you've ever sucked something up through your vacuum cleaner, that's the other half of it. So it pushes pressure in and then it pulls it out using a negative pressure. And it comes with two ways to do it. One is a mask. So for those that have difficulty raising their arms, it can be done with the assistance of a caregiver. And for those that can make a seal, there's also a mouthpiece that, for lack of a better example, looks like the end of a cigar that you would put on, form a mouth seal, and use the device. Generally, I recommend using it about twice a day for those with ineffective cough. First thing in the morning when you wake up as part of your wake up routine to get everything out that's settled in your lungs overnight. And then again before bed to allow everything out in the evening. When people are sick, I recommend using it more frequently. So we got that allergies, postnasal drip, we caught a little bit of cold from somebody and our nose is runnier. You can use it as many times as you need.
Thank you. You spoke a lot about sleep apnea and the effects of pulmonary while you're at rest. Could you speak a little bit to the recent effects of COVID and strains we're dealing with currently and how it affects the population here? Thank you.
In anyone who has an underlying respiratory condition, including neuromuscular weakness, you can be more at risk for a severe COVID infection, a severe influenza infection, or other viruses like RSV or adenovirus. Unfortunately, COVID has been quite difficult to treat. We don't have a lot of options in terms of treating with medications. There's some variable literature out there. If someone has an outpatient has a COVID-19 infection, there are some potential medications we can give early in the disease. So for me as a pulmonologist, when I have patients that are complaining of worsening cough or new cough, having fevers, having chills, I like to have them tested for COVID-19 and influenza. We have seen for my own clinic as recently as about 6 weeks ago, patients with muscular dystrophies with both flu as well as COVID. Luckily, we were able to keep them all out of the hospital, but early notification of your physician allows them to notify you earlier of potential antiviral medications. Masking, hand hygiene are very important. And it came with a cost during the COVID-19 pandemic. What we've unfortunately seen is socialization go down in general through basically the American populace, and people are afraid to go out. I don't want to strike fear into people that gatherings like this shouldn't happen. This is super beneficial, but it does mean wash your hands before you eat, carry that hand sanitizer. If you see people coughing, wiping their nose, things like that, steer clear. Protecting yourself is also important.
Was there a correlation as an increase as far as patients with myotonic? Were they affected at a higher rate than normal population?
That's a tough one to say because in the early part of the pandemic, when COVID-19 was much more severe and people were landing more frequently in the ICU, we weren't collecting all of that data.
Thanks. Couple things. One is we all experience going to a doctor with our family members who are affected by DM and feeling like maybe they don't have all the answers for us. They're not the specialists like what we see here at these conferences. So, for instance, my youngest son has a defibrillator and also is taking a beta blocker. And this is the first time I'm hearing potentially that's a conflict with fatigue, for instance. Probably should have known this already. However, point being, are some of the doctors, maybe yourself, available for consults from our specialists?
I think the answer to that one is yes. So you can always take information that you find, as they mentioned, on the MDF website to your physicians. This isn't something that every pulmonologist or sleep doctor gets a lot of training with. It does take delving into the community. I learn every day with my patients. I learn at conferences like this. We don't have all the answers, and there's no guarantee that even fixing one thing might make a huge change in how someone feels with sleepiness or fatigue, but it is worth noting. And so if you ever feel like you're not getting that specialty care, most local pulmonologists and sleep doctors would welcome the input from seeing a specialist, even if just once or once a year, to get some input on some things that might be available that they didn't know about before.
I was wondering how often should, if are using a CPAP, when should you be rechecked to know if you need a non-invasive device?
So if you've been started on a CPAP, my general preference is to follow your pulmonary function testing, your inspiratory and expiratory capacity, and then also your symptoms. So I have a litany of questions that I ask routinely. I probably sound like a broken record to my patients at the visit, but it's how I keep track over time as to what things are changing. So when that CPAP doesn't feel like it's helping with the fatigue, if there's headaches in the morning, if we're not sleeping well, if there's changes in the labs or the pulmonary function testing, then I say, let's amp it up. Let's make the transition from CPAP to non-invasive ventilatory device to help support breathing at night and see how we feel after that.
I've read that people with myotonic dystrophy, some people have trouble actually getting to sleep at night. Okay. What do you recommend in those cases? I have heard some people resort to prescription medication, some resort to medical marijuana. What do you recommend?
So insomnia is the bane of my existence in sleep clinic. It is very hard to treat, but the number one treatment is actually cognitive behavioral therapy for insomnia. And so that's looking at the things surrounding sleep that potentially are negatively impacting sleep. And that can include anything from going to bed too early and then recognition of other disorders. So maybe you're having trouble falling asleep because you're truly a night owl but didn't realize it. And so your preference is to fall asleep later and sleep in later. And that can be identified with a sleep physician. Restless legs, is that keeping you up? Is that keeping you from falling asleep? So looking for other things that can impact it. Medications for insomnia are only studied in the short term. So I do have patients that come to my clinic having been on sleep aids for a number of years to varying degrees of success. By the time someone sees me, if the sleep aid is working, 9 times out of 10, it stopped working. But there can be issues with a psychological as well as a physiological dependence on the medications. We do use them when we have to. For myotonic dystrophy, some of those medications we have to use with extreme caution. And those are benzodiazepines or benzodiazepine-like medications. Things like Ambien, Lunesta can potentially have an impact on worsening sleep apnea or respiratory function at night. Some other medications like doxepin could cause more dry mouth, dry eyes. If we're already having issues, that could be a problem at night as well. So there's no easy answer to that, but it is just everywhere a problem. And I would highly recommend seeing a sleep physician about it and talking about cognitive behavioral therapy and what medications potentially may be helpful for you.
I think we're going to have time for 2 more questions.
I have a question. I have a cough assist at home, the machine, and I also have a bed at home that I'm working on trying to use it at night, but I use it during the day. But I still have a lot of issues at night coughing where I can't stop. What can I do or take to control that so I'm not waking him up and waking myself up with an uncontrollable cough?
Sure. So that's a challenging question, and it does depend on the reason for the cough. So some things to look at: are you having postnasal drip or acid reflux? Other causes that may worsen cough at night that would need to be addressed. And that could be an indication that we might have some allergies or sinus disease that could also be addressed. Other things to look at for your doctor is, are we using our cough assist enough during the day at an effective pressure to truly clear out that phlegm before bedtime? And is our device that we're using at night actually at the right settings to really support our breathing? There are cough suppressants out there. What I will tell you is the reason they're over the counter is because in general, they might only have limited benefit. And that's definitely a challenge that probably requires an extensive visit with your physicians to kind of see what else we could be missing that could be contributing to that cough.
Okay, and I believe this will be our last question.
Hi, I have the excessive daytime sleepiness. I don't have sleep apnea, but I do have hypersomnia. And I have a problem with, and I was wondering if you have any suggestions. I have a problem with my insurance company approving, because Provigil doesn't work and armodafinil doesn't work either, approving any of the like methylphenidate or any of those. I was wondering if you ever prescribe any of those, and what do you say to get them to approve it?
So the excessive daytime sleepiness and myotonic dystrophy, as I said, we have some of those medications like modafinil or Ritalin. Ritalin didn't show a great benefit. It was used at lower doses. The reality is that there could be also a lot of other things affecting it. Not every patient that I see without myotonic dystrophy derives benefit from the medications, which is really challenging. So then we start to manage things like potentially, are naps helpful, are naps not helpful, things like that to kind of make changes to the daily schedule. It can be really frustrating. And unfortunately, across the board, even in narcolepsy, which is an excessive daytime sleepiness disorder that I have a lot of literature on, I have unfortunately patients that don't respond to medications. But it is worth talking to your doctor again to make sure that there's nothing else contributing to that sleepiness. And if you have that narcolepsy phenotype, what we don't know is that narcolepsy specific medications may be helpful. And that may be something important to help delineate if you fall under that narcolepsy phenotype of type 1 myotonic dystrophy. Should we try a medication? And obviously monitoring for certain side effects to see potentially if there's benefit there.
Okay, well, let's give Dr. Lowery a big round of applause.